Okay, here.
Okay, so welcome to the latest in our series of Candela webinars. Today's subject is expanding treatment options for women's health using CO2 lasers. I have great pleasure in introducing Dr. Palacios, who is a consultant gynecologist based in Madrid, and he has many years of experience in treating women's health issues with lasers. Just before I hand over to Dr. Palacios, I just want to run through a couple of things. During the webinar, if you do have a question, please use the Q&A button that you will see at the bottom left-hand corner of the panel on the right-hand side of your screen. And then at the end of the presentation, Dr. Palacios will answer your questions for you. So without further ado, I will hand over to Dr. Palacios. Thank you.
Okay, thank you very much, and good afternoon. I hope that all of you are well. In Spain, in Madrid, the situation is absolutely much better than before. We are starting doing our normal activities. And on the other hand, I am so happy to be involved in this educational webinar. Thank you, Candela, because we can speak about our experience during the last 7 years with the CO2 laser. I'd like to start with my conflict of interest, you can see here, but we decided to do this presentation to answer the most important question that usually after a symposium or a conference our colleagues make. This is so important, and the majority of them, they are so important, and if I can answer it well, you are going to understand how the situation in this moment is in relation with the CO2 laser and women's health. The first question is here. Is the use of CO2 laser is well known in dermatology, aesthetic, ophthalmology, surgery, but the use of laser in the vulvovaginal area is recent. And most of my colleagues, they like to know why. Why we are using laser in the vulvovaginal area only for the last 7 years. Well, I like to answer this question starting with exactly the number of papers that we have now in PubMed. Here you can see in this slide that if you put CO2 laser, and in general terms, you're going to have more than 12,000 papers, and with Terbium 3,000. But if you put CO2 laser and vulvovaginal atrophy, you are going to have 48 versus 7. If you put CO2 laser and genitourinary syndrome of menopause, you are going to have 57 versus 24, urinary incontinence 28, and finally vaginal laxity and CO2 5 versus 3 with Terbium. What does mean? That we have all of these papers published in important journals. Does mean that, well, we need to answer if all of these data they are enough for understand the situation. But let me say 3 important points in relation with vulvovaginal laser. The reason why we started 7 years ago, perhaps a little more, are due to the advances in biophysics. What are the reasons why we have now already CO2 laser for vulva and vagina for three reasons. First, now we have a minimum ablation, but without beautiful thermal effects. When we speak about ablation, I am speaking that the ablation is around 20 micras, more or less 3 cells lines. And the vaginal mucosa, they have more than 20 cells lines. Then we needed one absorption focus only in water, absorption coefficients in water. And this was another reason why we started 7 years ago. And finally, and this was fundamental, we need a fractionate laser only to work in small points and not around with normal tissue around, because if you do a total ablation, the pain after this could be enormous. That means that these three important advantages in biophysics were fundamental for using now laser in vulva and vagina. Minimum ablation, water absorption coefficient for water, and fractionate. Well, this is so important to understand, and you can see exactly in another manner the laser. The laser being destroyed around 20 microns, then you are going to have exactly one important carbonization area that is exactly the same, 20 microns, no more. Another coagulation area, a little higher, and finally, the most important point that this is the effect in relation with the hyperthermia that is going to be in the lamina propria in the vagina. All of these things, they can explain that we needed to have all of these things for working in this area. Other point is to understand after this, what is the mechanism of action of the laser? And I divided the mechanism of action in 3 different phases. The first phase, that is immediately after doing the laser session, I say the phase 1, that could be within 48 to 72 hours after, we are going to create one edema. This means that probably there are going to be some women that they are going to feel burning and itching after laser during this time. This is logical because you are creating an edema. And then, of course, release of chemical mediators, but they are going to be fundamental too at the same time to produce the neocollagenesis and the neovascularization. Then you are going to have a phase 2, that this is in relation with the following 30 days. In this phase 2, you are going to increase the fibroblastic recruitment, and you are going to have new extracellular matrix and new collagen fibers. And finally, in the phase 3, between 30 to 40 days, you are going to have all of the beautiful effects. In this slide, I can explain why we need to wait between 4 to 6 weeks between sessions. Imagine that you do 3 sessions during 3 days. You are going only to have the effect of the last one. That means that you need to wait all of this period of time for having the real good effects. I can summarize in this slide all of the CO2 tissue remodeling, the effects of the CO2. You can see here that we are going to have an ablation of the textural pigment changes, temperature thresholds, neoformation of collagen, neoformation of elastin, extensive documentation of histologies, this is great, neocollagenesis prolonged, and neovascularization. I'm sure that probably there are going to be some other effects in relation with some chemical substances that they are going to increase too. There are so many papers that they show the histology has been that this is a clear reality. This is our objective parameters when you can see the differences between the pre-treatment and post-treatment. No doubt about the neocollagenesis, neovascularization, and the increase of the elastic fibers. No doubt. All of these things, they can explain why we are using finally for all of the changes in soft tissue after childbirth, and this can explain too why we are using in all of the vaginal atrophy, genital lineages, menopause syndromes in relation with menopause. That means that while this can explain this question in relation with the use during the last 7 years of the CO2 in the vulvovaginal area. Move on to the other question, important questions in relation with the use of the CO2 laser in women's health. The question is, there is no consensus in the gynecology to consider that the use of CO2 laser is effective in the treatment of vaginal atrophy. Why? Why there is no unanimity? Do you think that there is enough scientific evidence? This is usual because there are people that they know anything about laser. There are colleagues that always they say, do you consider, Dr. Palacios, that there are evidence now with the laser? I'd like to answer because this could be fundamental for our colleagues to understand that we are speaking about objective parameters to explain that, of course, there are evidence. Let me say, what are the doubts that they have our colleagues? One doubt is there are not enough studies yet. Other doubt is the data is not consistent, or there is no long-term data. And other question is there are better treatments. Well, let me explain all of these 4 doubts that our colleagues have in relation with CO2 laser and vulvovaginal area. Let me show again. Well, we have all of these papers in PubMed, in important journals. Sure, that there are more, but with another product, with no doubt, or with another drugs, with no doubt. We have more and more papers to explain the efficacy of the CO2 laser for women's health. Let me present only some of them. This paper, published in an important journal, they say that, well, there are good experience for 24 months, long-term reliability of fractionated CO2. Others, like this, they explain that there are beautiful results after 36 months, 3 years. That means that the question is, well, when you consider long-term efficacy effects, I think that more than 1 year is clear. And we have so many papers to show this evidence. Other point, well, but we have other products, but they are much better, right? We have randomized double-blind placebo-controlled trials where we compare CO2 laser with a striol, topical striol, that this is one of the most usual local instruments for vulvovaginal atrophy, and published in Menopause, an important journal with no doubt. And the results are that both they work well at the cell level. The striol is a good treatment, and CO2 vaginal laser too. That means that laser works as a striol. Not only this, we have another beautiful paper where we compare CO2 laser with another usual local estrogen, that is promistrine. They say, well, they have, in terms of EVA, the same result, but the laser is much better in terms of urinary symptoms. Again, we can answer, no. There are. Double-blind placebo-controlled studies to show the same or perhaps better effect with laser versus local estrogen. In fact, let me to answer all of the doubts that my colleagues have in relation with this. In relation with, there are not enough studies yet. Oh, we have more than 50 studies in PubMed. Do you consider that 50 studies, they are not enough? Oh my God, this is clear. Perhaps 6 years ago would be true, but not now. They need to study and to go to the PubMed to see how many papers we have. The second is that the data is not consistent. All of results so efficacy. They are very homogeneous in relation with the results. The third point is no long-term data. Oh, we have data for more than 24 months, 36 months. Well, even more. No, I think that this is, we have that enough for saying that we have long-term data. And finally, there are better treatments. Well, we have similar results in comparison with local estrogens in DVA, and better in relation with urinary symptoms. Well, as you can see, we can answer clearly all of these questions. Move on to the third question. What is the most usual questions that our colleagues make? Other question is, I don't understand. This is a logical question. I don't understand why CO2 laser works in stress urinary incontinence. Can you explain the mechanism of action? The people, our colleagues, they understand that the laser, how the laser work in relation with vulvovaginal atrophy. But they have no clear ideas about why work in urinary incontinence. Well, as you know, there are 3 types of urinary incontinence. The stress urinary incontinence, that this is the most important one in terms of prevalence. The mix, that is a combination between stress and urgent urinary incontinence, and the urgent. Usually we use laser for stress urinary incontinence or mix, because, well, this is, you can work in the stress urinary incontinence. But you know, the pelvic floor is a horn and like a hammock. No, it's a hammock. That means that you need to improve all of this hammock, no? All of this area. But I can summarize in this slide what is the possible mechanism of action of the laser for improving stress urinary incontinence. Laser photothermal effect causes mechanical traction of the enormous lower, and this can contribute for adjustment effect. Other point is that the production of elastin fibers and stimulation of neocollagenesis This can increase the thickness of the vaginal epithelium, the elasticity and firmness of the wall that may be related to the restoration of urethral coaptation mechanism involved in the pathophysiology of the straight urinary incontinence. I can explain in this slide as simple as when you increase the neocollagenesis and elasticity, you are going to restore the urethral coaptation mechanism. And if you restore the urethral coaptation mechanism, you are going to improve the stress urinary incontinence. Move on to another important question. Question 4. What is the question 4? This is other typical question that our colleagues, usually during the symposium and congresses, they like to know. When you attend a gynecology conference about laser treatments in the vaginal area, hardly anyone talks about side effects. Are there any side effects with the laser in the vaginal area? What are those side effects? This is true. Usually we speak about the efficacy and not the side effects. Let me explain something here. For example, it was one publication in the menopause the last year about 4 cases in one important unit that with side effects after laser. They say, well, in one case, the lady had 2 vaginal walls laceration after resumption of intercourse. Other case, the lady had dyspareunia, in another dyspareunia and fibrous band, in another dyspareunia and insertional pain. Of course, if you use a lot, in a lot of cases, laser, they're going to have some small side effects. But if you see the publications like this, for example, with a lot of number of patients, the majority of the publications, they have that this is a very safe. And this is safe, but this is true that we need to take in consideration some different points to be sure that you are doing something safe. First is to follow the protocols. You need to know well the power of your machine, the energy that you are going to use, the fluency, the pixel density, and the number of pulses and mobility. In other words, protocols are there for following. This is as clear as I am speaking about. If you are using a core Intima, you need, of course, to understand what the protocol you are going to use in one specific patient or in one specific pathology. If you are not using the protocol, maybe you can have some side effects. Other point, to be sure that you are doing something sure, are the patient selections, symptoms evaluation, motivations, and skill of possibility of the laser device. Other point is to avoid, of course, contraindication. You know that all of these contraindications are in relation with women's health. You cannot use laser in pregnant ladies or women that they have in lactation period. Of course, you cannot use in women with vaginal infections and urinary infection because, well, the heart is going to increase this infection. Of course, you need to avoid doing laser in women with cervical and vaginal ulcers and boots and fistulas too, and women that are in this moment with chemotherapy or radiotherapy, in women with photosensitive drugs that are using photosensitive drugs or photochromic disease as melanoma albinism. You need to take into account all of this data for not using in women with this contraindication. Move on to another important question, question 5. Well, this is a beautiful question and very logical and very useful too. When do you consider leisure to be a better therapeutic option? When is your first option? Or when is, if you prefer, the gold standard use of leisure? We have a lot of different treatments, and this is true. If you see here this slide that my group did some years ago, well, for vaginal atrophy and for menopausal women, there are so many, hormone replacement therapy, local estrogen, progesterone, or spemifen. There are so many that they work, and with beautiful evidence, of course, that there are so many. But we need to consider that the majority of the local treatments, they have a very, very poor adherence. Well, there is one paper, beautiful, they say that using local estrogens only after 1 year, there is 11% of women that they maintain the treatment. There are all of women, they have some discomfort using all of this treatment. This is a beautiful paper published by Rosella Nappi. Other point is that, well, there are so many reasons that the women, they don't like the vaginal route as chronic treatment, inconvenient to insert, it interferes with the spontaneity, not discreet, and so on. But there are so many reasons for. In this kind of women, of course, you can use leisure. Other point, but this is for me very important, is the relation between CO2 leisure, use of leisure in menopausal women with breast cancer. But you know, there are beautiful papers here in the menopause, or this other, that this is a meta-analysis, that they say that probably the gold standard in women that they are suffering vaginal atrophy and with breast cancer or breast cancer survivors could be the use of leisure. In fact, we can answer this question to say, if you like to have better compliance, in other words, more efficiency in women that they suffer the genitourinary syndrome of menopause, you can use leisure. In women with breast cancer, you can use leisure as an important option. If you have no other option or more aggressive option, for example, in urinary incontinence, maybe you can, of course, to do one operation, but maybe this is something very aggressive, that you can try to use leisure in advance. And finally, for prevention. That means that, of course, there are so many reasons for using as fair option leisure. Move on to the question 6. But this is something very logical. This is a very, very useful question too. Do you think that this is necessary to have a CO2 leisure in our clinics? And if I think that yes, why? Well, let me explain. There are for me 3 important reasons for using for having one leisure in our clinics. First, let me say, well, imagine that you have a patient that suffers from vulvovaginal atrophy, and of course you prescribe local treatments as moisturizer or estrogens. And imagine that the women, well, or not comply or do not work the moisturizer or estrogen for her. What did you do? Well, you can use leisure, but you need to have the leisure. The second question is, imagine that you have a woman with straight urinary incontinence, mild or moderate, but bothersome, what do? Go directly for an aggressive technique for surgically, or do you prefer to use laser? Again, we can say that laser would be a beautiful option. And finally, this is so nice. You have women that after childbirth had a typical hyperlaxity syndrome with urinary incontinence and so on. What do? Of course, the unique option that you can do in this moment before surgically is laser. That means that, of course, if you have laser, you can have all of these things. And not only this, of course, one of the points that sure that is coming very soon is the use of laser not for treatment, is to use the laser only for prevention. I imagine to use the laser after 6 months of childbirth, because you are going to avoid the vaginal laxity, you are going to avoid the urinary incontinence, and you are going to have a return to normal vulvar and vaginal tension. And of course, if you use after menopause, you can avoid having vulvovaginal atrophy, urinary incontinence, and prolapse. This is exactly, probably, the most beautiful point for the future, is to use laser not only for treatment, is to use laser for prevention. And this is the unique treatment for prevention is, in this moment, laser. And finally, this is the last question, and then I will open for questions. For me, do you know any novel clinical study that support the evidence of the use of vulvovaginal laser? There are coming so many. I can say that they're coming, and in fact, if you look all of the clinical trials that are coming, there are so many clinical trials going doc. You can see all of the studies that they are coming with laser. If you see, for example, the studies from the last year, or for this year, in fact, there are some of them. I am going to explain the first one because this is found in my group and published this year in 2020. It's in relation with urinary incontinence that I think that could be important, but there are coming so many of these. Well, I did this study with the CO2 laser. This is myself working in my clinic. And well, we work in women with straight urinary incontinence and mixed urinary incontinence. And we did these two questionnaires, the famous ICIQ UI questionnaires and the severity questionnaire, Sambic Index questionnaire. And we did 3 sessions, laser training in the internal area, with 2 paces by session, 360 grades for the vagina with an energy of 70 millijoules and affluency of 396 joules per centimeter square. And another, the second phase was 90 degrees in the previous phase of the vagina. This means that it's the usual protocol for urinary incontinence that you know very well. Well, of course, before doing a laser in my clinic, always we are doing a pap smear, a urinary culture, a vaginal exudate, and a gynecological ultrasound. Is to avoid exactly having any infection, vaginal infection, any cervix problem in relation with, for example, SPV, human papillomavirus, and some other infections. And the gynecological ultrasound is to avoid that women had, for example, ovarian tumor or some other problems. This is to know what's happened there. This is the typical thing that we use. We usually recommend. Then other previous recommendation that in my clinic we are doing to explain to the patient that this is a safe technique because they arrive the first time, the first session, very nervous, and you need to avoid. Explain that this is not a surgical or ablative treatment. It is a photothermal treatment. Do not use washes, soaps, or moisturizer unless 1 week prior. We need to have very dry the vagina, no? No local anesthesia required, no previous treatment required, and no hospitalization required. Of course, you can use an anesthetic cream before doing the leisure, but I recommend that you are the person that needs to do it, not the patient for herself. Well, the recommendation during the treatment, and this is so important, we need to dry the vagina very well because if no, you are not going to have a beautiful thermal treatment. No need to disinfect the vagina. You don't need to do it. Use the large speculum for a more comfortable application and turn it. And if the patient feels a lot of pain, we should stop. This is something logical for all of us, no, to do it. After doing the leisure, we recommend avoid sexual relation, avoiding trauma to the area during 5 days, around 5 days. Avoid things, clothing, avoid sources of heat, sauna, spa, etc. Avoiding heavy exercise, and if they need, they can use paracetamol. These are the recommendations that we usually do. Well, let me to answer what were our results in terms of urinary incontinence and the core intima leisure use. Well, after the first treatment, we decrease clearly the number of urinary incontinence with a very significant manner. Then after the second one, exactly, we improve the straight urinary incontinence and the mixed urinary incontinence, and then we maintain the effect. In terms of ICIQ questionnaire, you can see exactly the differences. You are going to improve the straight urinary incontinence and the mixed urinary incontinence at the same manner. This is important because we are going to have a huge number of women that they are suffering stress and mixed urinary incontinence. When you like to know the severity by the Sandwich index, exactly, let me before the training, the number of moderate, serious, and very serious stress urinary incontinence and mix, and then how is improving clearly after the number of sessions. Again, we can say that CO2 was very nice in relation with the urinary incontinence. Here you have the results. After 3 core Intima session, there is a significant improvement in both urinary stress incontinence and mixed urinary incontinence. The improvement was similar for stress and mix. There was improvement in sexual function. Of course, this is secondary for the beautiful effect on the straight urinary incontinence. And 92% of the patients were moderately or very satisfied with the procedure result. This is so important because, well, we need to maintain the number of patients that they are coming. We can summarize in relation with the core intima leisure and urinary incontinence, but this is for the first time I studied in urinary incontinence with core intima, and the best improvement result found in the literature. This is so nice. Mixed urinary incontinence is a study for the first time, and this is not only stress, mixed urinary incontinence too, and the patient study were with moderate and severe symptomatology. That means that this is important that we can use in this kind of patient too. Well, let me do the last, this is the last slide. Well, the future is fantastic for leisure. Of course, we need to to do a lot of studies. We need to maintain our actions. We need to maintain our work. Sure, but we need to know more about the benefits and how to improve all of the benefits that we are doing. Of course, we need to understand more about the side effects and to look for the better protocol, of course, and we need to make a lot of questions, because if you make questions, we need to have answers. And this is exactly all of the action that we are doing. In other words, leisure, CO2 for women's health is a big reality, and of course, we need to continue working and doing research. Well, thank you very much to all of the attendees that they are there, and now we have time for questions. Thank you very much.
Thank you very much, Dr. Palacio. Can you see the questions? We have one question so far.
Yes, I have some questions here. The first question that this is very nice is do you use CO2 laser in VIN and in vulvodynia? This is a good question. Well, let me say, if you have some pre-cancer or cancer lesions, of course, you can use laser, but in another manner. But you know, you can use laser only for the thermal and biochemical effects. That is exactly the talk that I was doing for vaginal atrophy, for laxity syndrome, and for urinary incontinence. But of course, you can use laser to cut, for example, and for coagulation. And to use laser in relation with coagulation and cut for precancers and cancer, of course, that I use. And if you, for example, are a gynecologist or an aesthetic doctor, and you can do as you are a surgical doctor, of course that you can use the laser as for coagulation and to cut, for example, the tumors and so on, of course. That means that yes, but no with the thermal effects. And in terms of vulvodynia, this is a very, very, very nice and very beautiful question, because but my answer is yes. I use for vulvodynia, but probably first I need to know the cause of the vulvodynia. If it's the typical unknown cause of vulvodynia, I use PRP in combination with laser, because this is another question, is the combination of the different treatments that we can use. And in terms of vulvodynia, I use PRP and laser. This is something that, well, they work very nice. But the point is that if the question could be, do you know papers in PubMed to show this effect? The answer is no, until now. Probably we are going to have very, very soon papers with laser and vulvodynia, but until now we have no any. Only we have the experience of the person as me, for example, that we use. But in my case, I use PRP and laser for this. Well, I have another question here. But this is, do you think that is the first option in women with VVA and breast cancer? My answer is yes. if you have a woman with breast cancer, as you know well, you cannot use local estrogens. And of course, you can use moisturizers. But as you know, the moisturizers, they have a moderate effects. In other words, if you have a women, and there are so many young women that they are suffering breast cancer, the better and quickly effect and safe is using local lesion. No doubt. Not only this, I can say something more important. I spoke 3 years ago with the Spanish Oncology Society to say and to offer it that there is a new possibility for women that are suffering breast cancer and vulvovaginal atrophy, that is the use of laser. And they were very, very happy. Why? Because, well, they are concerned with the use of the local estrogens. That means that the answer is, of course, you can use in women as fair option in women with vulvovaginal atrophy and breast cancer, laser. Not only this, I recommend strongly this point. Other question is, do you know something about the macrobiota, vaginal macrobiota and laser? Yes. There are 2 papers in PubMed to say that if you use laser, you are going to remodulate the macrobiota and to have a new macrobiota. This is something that, well, 2 papers are 2 papers. This is not enough. But this is something exciting for research. And this is logical, because if you are going to have 20 microns of evaporation of the cells in the vaginal mucosa, you are going to restore a new microbiota, and probably you can avoid the chronic infection in some women. This is something exciting. I cannot confirm because only the 2 papers they are not enough, but this is something that my colleagues, but they have a huge experience too, and myself, we are thinking to do. I mean, the microbiota and laser is another chapter for the future. And finally, there is the last question here is in relation with, well, do you have experience with laser treatment on vulvar lichen sclerosus or lichen planus? Oh, this is a beautiful question too. This is a beautiful question. Well, let me say first, lichen sclerosus is an immunological disease. That means that you never are going to cure until now. This is the first answer. The second answer is the gold standard of the treatments are local corticoids, no doubt. But let me say the third point. If you like to decrease the use of the local corticoids, of course, that you can use laser. Another point is that there are better and better experience for using PRP and laser in combination for improving lichen sclerosis. In other words, there is a clear role of the use of laser in lichen sclerosis. No doubt in this point. This is a very nice question, in fact. And I think that the lichen is going to be one of probably the most important area for the next years. because now there are more and more lichens. I don't know, because, probably because we make better diagnostic. That means that probably this is going to be an important chapter area. But yes, I use laser in women that are suffering lichen and severe lichens, and and in combination with PRP, and of course, I recommend to the use time to time the corticosteroid in the area. Well, I think that we have no more questions. I think that we have all of this area covered, and I know that there are still a lot of colleagues attendees, but well, this is a pleasure. I recognize that laser is something very provocative, is something that we need to work a lot, but this is fantastic at the same time. In my country, in Spain, there are so many colleagues that now they are using laser, and this is a very active area because there are so many questions, and when there are so many questions in an area, it's because this is something that works and we have a huge interest. I recommend to have more of these sessions. I like to finalize to say thank you very much to Candela for this possibility, and I am so happy to be involved in all of these seminars and all of these talk and these webinars, because this is fantastic. And I would like that all of you, if you have better or some experiences, I am free to know all of the data that you are going to have in this concern, in this area. And well, thank you very much for being here, and bye-bye, and good afternoon, and good day for all of you.
Dr. Palacios, thank you very much. Very, very interesting.
Thank you.
Thank you. So I think we have no more questions. I think we will end our webinar. And thank you, everybody, for attending.
Thank you.